Thanks, James, and again, welcome everybody to this presentation that we're doing this morning or this evening, depending on where you are. The Australian Healthcare and Hospitals Association is very pleased to be working with the IHF on this presentation. The AHHA is the peak body for public and not-for-profit healthcare providers across Australia. And today we're going to be talking about social determinants of health, but particularly with the view from Australia and what the situation here is and some of the key data that can inform policy and activities in the country and hopefully help people around the world as well. So I'll hand over now to Linc Thurecht, who is our Senior Research Leader at AHHA, to give the presentation. Thank you.
Thank you, Andrew, and thank you, James. Hello to everybody. It's a pleasure to be able to do this presentation today. We're going to be talking about social determinants of health in Australia, some of the important health issues that are being faced here, and some important developments that are occurring. Okay, I'll proceed. So we'll be talking about social determinants of health, some aspects of the Australian health population from a health perspective, and some important recent developments that have happened here as it will relate to social determinants of health and the healthcare system in Australia in the future. Well, given that we have an international audience here, just give a very brief overview of what the Australian population looks like. We are a country of a little over 23 million people. The increase is a little under 2% a year, but very importantly, and this is something which we'll revisit shortly, about 40% of the population increase is natural, but 60% is from net overseas migration, and that produces particular challenges that the Australian healthcare system has to respond to. Another very important feature of the Australian population is the number of people who are of Aboriginal or Torres Islander descent, Indigenous Australians. The latest statistics we have is a little bit under 700,000, or about a little bit under 3% of the Australian population. But we are experiencing over recent years an increase in the number of people who are declaring themselves to be of Aboriginal and Torres Strait Islander background. So we're expecting those numbers to increase faster than what natural increase would suggest. And as we'll talk about shortly, this segment of the Australian population has particular issues that the healthcare system is challenged to meet. Probably the other major aspect of the Australian population which is worth drawing everyone's attention to is that we do have in Australia a structurally ageing population. Now, pardon me, that's not uncommon across the world, but in the Australian context, you can see with this this chart here, and in particular the line on the right-hand side, that the combined dependency ratio is really rapidly increasing over a fairly short period of time, in the next 35 to 40 years, is projected to go from a little bit under half to about 66%. So what this statistic measures is the number of people who are under 14 or over 65, so they're not in the workforce, divided by the number of people who are in the workforce. And as that ratio rises, there's less people of working age available to not only provide the tax revenue to provide the health services and the educational services that are going to be demanded, but also it creates a lot of workforce issues as well, which Australia needs to plan for. Not sure how familiar the international audience might be with Australia. Australia is the sixth largest country in the world. From east to west, it's about 4,000 kilometres. From north to south, it's also about 4,000 kilometres, depending how you want to measure it. But we've got a relatively small population, but it's very clustered. And the majority of the Australian population resides in the southeast corner of Australia. So sort of down, oops, sorry. I'm not sure everybody can see, but the majority of the Australian population is in the southeast corner of Australia, but there are clusters of populations elsewhere. So up here around Brisbane, there's about 2 or 3 million people. Over here in Perth, in the greater Perth area, about 2 million. Over here in Adelaide, about 1.5 million people. But looked at another way, we can see that there are clusters of population quite scattered and dispersed across Australia. And that has implications for how, certainly for the healthcare system, and hospitals in particular, how those services are provided to Australians when they're quite concentrated but dispersed at the same time across quite a large area. So we'll see the implications of this kind of population distribution in some statistics, which I'll show you shortly. Okay, I'll just give a little bit of background to the Australian healthcare system. We do have a universally federally funded healthcare system that covers hospitals, pharmaceuticals and medical services, but we also have a large private sector that also provides hospital services, medical practices, pharmaceuticals. I didn't include in the slides, but also allied health services as well. But even though we've got a universal health system, this table shows that the federal government, which is the largest source of funds for the healthcare system, only covers a little over 40%. And in fact, private funds contribute over 30% of the cost of total healthcare in Australia. Well, when people think about how healthy Australia is, it's generally seen as being one of the healthiest countries in the world, and there's a lot of evidence out there that shows that Australia does, relative to other countries, perform very well on a number of important statistics. The Global Burden of Disease report in 2010 showed that Australia was not only in the sort of top 10 of countries across a number of standard statistics of how well the health of the country is going, but in the period from 1990 to 2010, Australia in fact increased and went up to the top 5 across most of these things, most of these indicators of health. So looked at from this point of view, Australia looks like a healthy country. More recent evidence was provided by the Commonwealth Fund, where they examined, I think it was 11 countries, 11 developed countries, to see how their healthcare systems performed. Overall, Australia came fourth with that. We also were shown to have the third lowest per capita healthcare costs across the 11 countries considered. But one standout feature of this matrix that's shown here is where Australia does not perform so well relatively is on access. And if you think back to that map of Australia that I showed where the population is clustered, you start to get a sense of the challenges that are faced in reaching out to the fringe communities as you get away from urban centres. Obviously, health and hospitals is an important thing, but when we think about social determinants of health, this obviously impacts on other things like education, access to job opportunities, access to fresh food even. And that's something which Australia came out number 4 here, but as we go down and look at individual statistics, there's some early indicators of some problems or challenges that we face in the healthcare needs of all Australians. Well, the last one I'll show to just demonstrate that Australia is a healthy country is the life expectancy table taken from a report in The Lancet in 2010. And it shows that Australian men have the 5th highest life expectancy and Australian women the 10th highest life expectancy across the world. Male life expectancy here in Australia is in fact currently 79.9 years and for females 84.3 years. Well, that's a good news story, but as we peel down and look at those numbers a little bit more closely, it reveals that there are actually a number of challenges that the Australian health system faces in trying to meet the needs of Australians. If we first of all look at some disability statistics, some evidence that came out in 2012 shows that around 4.2 million people, or close to a fifth of the population, actually have at least one disability. And of those, 60% need help with at least one everyday activity. And of those, nearly 40% their needs just are not met. Now, when you crunch the numbers, it works out that there's about 1 million Australians out there who have a disability, need assistance, and they're not getting it. Furthermore, about a fifth of these people don't participate in cultural, recreational or sporting activities. And this very much speaks to the social determinants of health in terms of being socially engaged, in terms of being intellectually engaged, in terms of having access to the kinds of services that help people with their disabilities or in fact delay the onset of various chronic conditions. I mean, dementia is an obvious one that comes to mind. So we've shown that Australia is a healthy country, but a fifth of the population here is shown as having, problems that are important and need to be dealt with. This next slide shows obesity rates in Australia in 2012, I think it was. And this is a fairly disturbing chart, but it shows quite a few things. I guess the first thing that's obvious is that there is a clear social gradient as it relates to obesity. The lower your socioeconomic status, the more likely you are to be obese, and of course that is a risk factor for a number of chronic conditions. You also see that males are more likely to be obese than females. What's not shown here is if we included the statistics on being either overweight, being either obese or overweight, in 2011-12, around 63%, that's 63% of the Australian population were overweight or obese. That's based on BMI, which I just find that personally a very confronting statistic to being told. Having said that, there is also spatial distribution associated with that. For example, in eastern Sydney, about 49% of adults are either overweight or obese. But as we go to an area west in New South Wales, sort of in the middle of New South Wales and north a little bit, it can get as high as 79% of the entire population is overweight or obese. It's thought that in Australia, obesity causes direct healthcare costs of about $2 billion in 2008, which that's roughly about 2% of total expenditure in health is related to obesity. And those people who are obese, their costs are 30% higher to treat a comparable condition for someone who is not overweight. So that's a fairly distinct picture and portends the kinds of challenges that the healthcare system is going to face in the not too distant future. This slide shows exercise rates, and once again we do have social gradient, but it's not as distinct. And also we see now it's females who are more likely to have insufficient exercise, as this is reversed, but the rates aren't so different. Now we don't actually know the specific reasons for this. It could be an issue of health literacy. It could be an economic effect related to the challenges of maintaining a healthy diet, and certainly as you get away from urban areas that does become an issue. And it could in fact be something as basic as having access to fresh food, which in remote areas in Australia is definitely an issue that is faced by Australians. Having said that, the underlying situation is actually even more complex than that. What this chart here shows is the joint distribution of risk factors for the most disadvantaged and the most advantaged quintiles of the Australian population. It takes a little while to take in this chart. I think it shows two distinct gradients. First of all, if you've only got none, one or two risk factors, you're more likely to be in the least disadvantaged socioeconomic quintile. However, as the number of joint risk factors increase, you're much more likely to be in the most disadvantaged socioeconomic quintile. I've shown here I think there's 8 different risk factors that this is based on, but this is really an early look, a bit of a window into the cumulative lifestyle-related factors which a large Australian population are carrying with them that in the near future is in all likelihood going to manifest in a number of chronic sort of healthcare conditions that will need to be treated. The other thing which is kind of a bit disturbing about this chart is if you kind of just do a quick mental add up of each of those bars, a large proportion of the Australian population, whether they're well off socioeconomically or not, have a large number of risk factors. So even though we do very well on the international league tables, the underlying problems are masked, and there really is, in all likelihood, some real challenges emerging in the very near future. So just to show one more time, this is the self-assessed health status by socioeconomic status. This once again is a clear distribution. And bear in mind that while this is socioeconomic status, that's not just about financial and economic resources. It's also about education, the type of employment they have, their life course health, and their life course lifestyle-related risky behaviours. And these are all things that contribute towards social determinants of health. Okay, well, one of the issues which is well known here in Australia is with healthcare needs of the population is there's an urban-rural divide. If you think back to the chart I showed, or the picture I showed before of the population distribution spatially, the spatial distribution of the population across Australia, what we can see here is that as your population goes away from urban areas, they're much more likely to have, or much less likely rather, to have self-reported good health. Now that is very much an issue around access to hospital services, other health services, but it's also about access to things as basic as fresh food and stuff like that. And when you get to more remote communities, it's definitely the case that they do not have access to the kinds of everyday food items that in an urban environment that you take for granted. I've been talking about the distribution of the Australian population and as it gets away from the urban areas, how different it is, but in fact the problem is a little bit more insidious than even that. Australia, I think probably normally around the world, has a bit of an issue of urban sprawl, so development, growth for the population tends to occur on the fringe of existing urban developments. Those areas tend to be lower cost housing, so it's more accessible from people at the lower end of the income distribution, people who are less well off. As these developments are put in place, often the necessary social services don't follow with them, so they don't have access to adequate public transport, so that limits their employment opportunities, or they may not have access to local education services. So all the kinds of things that we think about in the areas of social determinants of health, often the people gravitate towards areas where it's already worse for those sorts of things. So we're kind of embedding this disadvantage that this segment of the population face. So when I talk about social determinants of health, another way of talking about this is the health equity and the long-term consequences of not having social services in place today for this segment of the population. I talked earlier before that 60% of Australia's increase in population comes from immigration. One segment of our immigration intake is refugee and humanitarian people. This is a politically very sensitive issue in Australia for reasons which regrettably appears on the news far too often. But from a health system point of view, these people come to Australia with a lot of health problems, either from the circumstances they've been in most immediately, or the way they've the way they've lived their entire life, with perhaps not adequate access to food and basic healthcare and that sort of stuff. So they come to Australia not only with their pre-existing conditions, but then in Australia they face a whole bunch of challenges in terms of barriers relating to language, culture, and understanding how to access health services in a very different institutional kind of framework than what they might be used to. Just to give a sense of those numbers, Australia's total immigration intake is sort of pushing towards 200,000, with the refugee and humanitarian sort of between 15 and 20,000. Although there has been a policy announcement recently that's going to be increased by another 5,000 people. So this is a segment of the population which is known to have particular health needs, and which the healthcare system is not currently adequately addressing them for a number of reasons related to, as I say, language, education, economic capacity, access, all those sorts of things. I mentioned before about Aboriginal and Torres Strait Islanders, the problems they face. This is a particularly disadvantaged group within Australia. They only make up less than 3% of the population, but I've got some statistics here on how they're far more likely to have a number of long-term chronic conditions and risk factors for other conditions to develop. Life expectancy for Indigenous Australians is, for men, it's about 10.6 years less than non-Indigenous, and for women it's about 9.5 years less than for non-Indigenous women. They're also more likely to be in rural and remote areas, which also speaks to the issue of access to healthcare services. Having said that, there's some interesting statistics that we were able to put our hands on, and showed that for Aboriginal and Torres Strait Islanders, as they go to school for another 1 or 2 years, what we see here is a quite rapid decrease in the percentage of them which are smokers. So if they leave school before year 9, as opposed to completing year 12, which in Australia is the end of secondary schooling, they're half as likely to be smokers, which is just a stunning statistic. Now, we can't, we obviously can't infer any causality associated with that, but we certainly can say there is a strong association between education and smoking rates. And is a significant marker for social determinants of health. likely behaviour of people as their educational levels go higher. Well, just to put some numbers on this, an exercise was completed in 2012, which looked at the different health distribution of people in the lowest socioeconomic quintile compared to the highest socioeconomic quintile, and posed a counterfactual thought experiment. And what this study showed was that, first of all, 12% of all hospitalisations were by people who were in the lowest socioeconomic quintile and who reported health. So about an eighth of all hospital services provided just this one segment of the Australian population. But it's also estimated, and this is important, that if the health gap could be closed between this segment of the population and the high socioeconomic quintile, then that would generate savings of about 5% in total expenditure on hospitals. So $1 in $20 could be saved if that health gap could be closed. Now, obviously, closing that health gap is a difficult thing because of all the sorts of problems I've talked about before, but it shows there's an immense opportunity to generate, depending how you want to look at it, either generating savings in the health system or opening up capacity for those health services to be delivered to other people. Okay, well, I was going to shift the discussion just a little bit now to thinking about the institutional and, I guess, political framework in which healthcare is delivered in Australia, because it's becoming an extremely topical issue at the moment, and there's some potentially large changes in the wings. We have 3 tiers of government in Australia, at the federal level, at state and territory level, and then at local government level. The federal government pays for general practitioners, out-of-hospital pharmaceuticals, pathology, some imaging, subsidised private health insurance. State governments are largely responsible for delivering public hospital services and partly for funding it, and also for community care. And local governments get involved in a range of public health initiatives. Their role is important, but in terms of overall health expenditure and the delivery of healthcare services, it's a relatively minor role. I could talk about this in a lot more detail, but in Australia there's this problem which is labelled the blame game, and what it relates to is gaps and overlaps between primarily thinking about federal government and state governments in who is responsible for providing certain services, and more particularly who's responsible for funding those services. And it generates gaps and overlaps in what is done. There's a lot of active work in cost shifting, so if the states can get things, can deliver services in ways which will be funded by the federal government, they kind of game the system to do that. And the problem is really one of coordination and taking responsibility within the healthcare system. Now, that might sound like an obvious thing, but this is an embedded system which has been going for many decades. And in a slide I'm going to talk about shortly, there's a move to try and break this, what's called the blame game, where responsibility is clearly centred on one tier of government, and the funding capacity is put in place that they can actually deliver those services and not just point to somebody else and say, well, we need to do it, but we don't have the funds to provide those services. So I've got here a slide on federalism. It's in some senses a new debate, but here in Australia it's actually not. It's probably federation back in 1901. Just for our international audience, I'm not sure if you're aware, but prior to 1901, Australia was not a country. It was a set of 6 different colonies of the United Kingdom. And in the late 19th century, there was a move to federate towards the Commonwealth of Australia, and in fact on the 1st of January 1901 we became a single country. Most of the powers constitutionally rest with the states and territories. However, over the past 113 years now, there's been increasing incremental shift of responsibilities towards the Commonwealth government of the states and territories, and also importantly the Commonwealth government has far and away far greater capacity for revenue raising. Now, they do pass on funds back to the states and territories to help them fund hospital services and the like, but you can imagine there's a real tension between how those funds are divided, and the Commonwealth has got its own responsibilities and its own need for spending. So this federalism debate, what it's talking about is rethinking who is truly responsible for providing health service, other things as well, education, housing, and the like, but who is truly responsible for the provision of health services, the delivery of health services, the policy around the delivery of those health services, and what can be done to better equalise the revenue raising capacity to fund those services. So in Australia we have, not uniquely across the world, but a vertical fiscal imbalance where the Commonwealth can raise significantly more revenue than what the states can, and that creates a system where the two tiers of government play off against each other. But if we can take a more holistic approach to this, where responsibility and funding revenue raising capacities at one tier of government, there's potential for better health outcomes, for a better patient experience, for better health system planning, and to be more cost effective. Oops, sorry. Expressed another way, this federalism debate provides the opportunity for the social determinants of health to be better addressed, to be thinking about more than just how hospital services are delivered, but also preventative healthcare and the importance of trying to keep people in education for longer, because that higher educational attainment is, in general, associated with better health outcomes, to have a better coordinated set of social services that are delivered, to recognise that the transport constraints can have an impact. So to have that more kind of view of the health system, that's the opportunity, and I guess the challenge that is provided by this federalism debate. It's a contentious issue here in Australia. It is something which the current government has said that they want to take to the next federal election, propose to the Australian people this quite significant change in the way services, responsibility for service delivery and revenue raising should be done. But it's something which at the AWHA we're trying to take a lead on, and it's a very important issue for in Australian public policy, beyond Australian health policy. Well, the last thing I wanted to talk about was we recently attended the G20 International Health Summit. Now, probably everybody's aware of the G20 summit, where all the leaders from 20 main countries across Australia come together and discuss what they choose to discuss. What you may not know, but what may not be as widely known, is that there were also a number of what they call engagement groups that were produced, that were put in place to support these and deliberations of the G20. And there were 5 of these groups to do with business, civil society, labour, thinking, and youth. Now, those are all important issues, and they deserve their own special attention. But what is notable for its absence is there was nothing there on health. So a group of in Australia decided to put together a H20 summit, where they brought together a lot of people from across Australia internationally to discuss what was seen as the important issues, and to in fact report back to the G20 to try and give some visibility to these issues. Across the 2 days, there were a number of speakers and panel sessions, but the following 4 issues are the sort of things which emerged from the summit as being among the most important issues that need to be considered. First of all, a common theme was that health should be seen as an investment and not a cost. That very much speaks to the idea of preventative measures and trying to avoid expensive interventions down the track by not letting them to occur in the first place. And if you think back to some of those population distribution health statistics that I showed you before, that certainly is not in the thinking of healthcare system planners here in Australia. Another thing that kept coming up at the H20 summit was the social determinants of health, that we've got to think it's really important to think beyond just what the patient needs when they present at the hospital. It's really about what led up to them being there and what can be done to try and avoid those sorts of things occurring in the future. Non-communicable diseases was also raised as a very important point. It's something which is not recognised for the burden and the cost to the health system that it represents. A startling contrast was made between the number of people who died by the Ebola virus, and as terrible as that is, the statistics on the number of people who are dying for HIV are far greater. And yet there is so much more publicity and resources being devoted to grappling with the Ebola outbreak. Now that is important. I'm not saying that shouldn't occur, but non-communicable diseases is actually responsible for a far greater burden of disease and early deaths than some other higher profile health issues. And the fourth thing that came up at the summit was the importance of climate change in health. And a number of speakers spoke to how it's already starting to impact on populations that they work with, and how that's is likely to impact in the near future. Well, I'm not sure how I'm going for time, but those are the things I had to talk about. I guess the main thing that I would say to the audience here is that Australia is seen as being one of the healthiest countries in the world, and I guess you can't. It's important to look under the lid and look at the distributions beneath them, and there are in fact some quite disturbing trends developing in Australia that portend potentially significant burdens of disease and needs for health intervention in the very near future. And that's something which it's important that healthcare system planners think about beyond where the next hospital is going to be located or where they're going to hire the next doctor from. Taking a broader view of the social determinants of health that lead up to the health conditions that people ultimately will develop is an important thing that shouldn't be lost sight of. So I might finish there and hand back to Andrew. Yeah.
Okay. Thanks, Linc. What we're going to do now is give you the opportunity to pose some questions. And what I'm now going to do is flick back to James, who will describe how you go about posing some questions to us. We'll give you a few minutes to get those in, and then between Linc and I, we hopefully will be able to give you some answers. Okay, Peter from Canberra has asked whether there are national or state-based strategies to tackle the social determinants of health. Unfortunately, I think the short answer to that is no, particularly at the national level. Last year, the Australian Senate held an inquiry into Australia's response to the World Health Organisation's policy paper on addressing the social determinants of health. In that, their report identified a range of actions that could be taken, which predominantly related to expanding the focus on addressing the social determinants of health beyond health, the health departments and the health system itself. It called for a national approach. It called for national consideration of the impact on social determinants of health for all government policies, so a health in all policy approach. It also called for an annual report on progress. Interestingly, that report was a unanimous report, so a bipartisan support from both sides of politics in Australia, which was encouraging for a large group of people. But unfortunately, nothing has yet happened as a result of that. At an advocacy level, there is a national group, the Social Determinants of Health Alliance, which is a collaboration of a large number of peak bodies, professional associations, colleges, who are working to raise the profile of the issue and to encourage governments and councils across the country to take action. But as far as a national strategy, I think we've certainly got a lot of work to do to get to that point. That said, though, at various levels of government, there are pockets of excellent activity that are going on to address issues around access to food, employment, transport. But as far as a coordinated approach, I think we've got certainly got work to do in that space. So if anybody else has got any other questions, if they'd like to type them in to the message board, that'd be great.
Is a question saying that our group wanted to know how was insufficient exercise determined or measured?
Right. There was a large national health survey that was done that measured people's exercising habits. Now, the specific thresholds, I forget, so don't hold me to this, but I think it was something along the lines of if people exercised between 60 minutes and 150 minutes a week, in at least 3 different sessions. Now, I forget the specifics of it, but it was something like that. It was a certain amount of time each week, a certain number of times each week, on a self-reported basis on a large health survey.
I might respond to a question from Peter around the potential role of primary health networks or a more highly developed investment in community health to address social determinants of health. And certainly we could be hopeful that there will be some improvements there. For those who aren't aware, the primary health networks are a new structure that's being put in place across Australia to replace an existing but relatively recent introduction of what were called Medicare locals, which are basically primary health organisations that will be responsible for coordinating the delivery of primary healthcare services. They will be commissioners of service, but not direct providers, unless there are unique circumstances that, such as a market failure. There's a lot of potential there, and certainly some of the existing Medicare locals were doing a lot of work across engagement with local councils and state governments and with the acute health sector to put in place programs that were going to tackle many of the social determinants of health, or at least contribute to tackling them, or at least raise the profile of the issue. It's yet to be seen really how those primary health networks will evolve and what their role potentially can be. But certainly from the AHHA's point of view and our work with groups like the Public Health Association, we're certainly trying to shape the role as much as we can through our interactions with government. But we'll wait and see on that one. I think what the data, some of the data that Linc presented, which showed that despite Australia doing well as far as our health outcomes, beneath that is the high level of disability and the high levels of risk factors, which kind of suggests that we're a country that's good at treating ill health and disease, but not so good at preventing it. So certainly any increased investment at the community level beyond, but particularly I would say beyond the health structure and the health system. There's only so much that can be done by health service providers to address the issues. One of the points that was raised at the H20 conference that Linc mentioned was activities in the UK where they're trying to encourage the general practitioners not just to assist with completing the form to assist someone to get supported housing, but to follow that up with, I guess, action to highlight what is contributing to that need. So trying to get senior health clinicians and leaders to become advocates beyond their health area.
Could I perhaps just add one thing to that last question?
Okay, yes.
With the social determinants of health, it's widely recognised the importance of the life circumstances in which people live. One of the challenges of trying to deliver on what social determinants of health is pointing out can be achieved is the difference in planning horizons. A lot of the social determinants of health are very long-term kinds of things. And the benefits are not directly measurable, and so that makes it a hard sell with government. And so I think it's really incumbent upon us within the health sector to keep communicating that kind of message, because it is a political challenge to fund some of these things. Traditional planning horizons in Australia, anyway, are only sort of 4 years. The electoral cycle are 3 years. But the social determinants of health, a lot of the things we're talking about there are generational kind of changes. So recognising the importance of social determinants of health is obviously important, but communicating to people where the horizons they're thinking about are so different makes it a real challenge. Thank you.
Okay, we have no more questions.
Thanks everyone for participating, and thank you to the IHF for the opportunity.
Yeah.
Yes, thank you.
Okay. Well, thank you everybody for staying with us these 50 minutes.